Hello, my name is Eishar Sekhon, and I'm currently in California. I'm from the Bay Area, and this summer 2025, I was in Ecuador for almost a month for 3 weeks. And today I'll be showing you some key findings we did from the cervical cancer screening campaign, and we'll go over demographic trends, clinical outcomes, and public health recommendations based on our analysis. Yeah. So now I'll go over some key descriptive statistics from the screening campaign, just the most important numbers to give a sense of who we reached and the health indicators we measured. So on the continuous or descriptive statistics, the average age of participants was around 40 years old and it ranged from 15 to 77. Weight was around 67 kilograms and pulse was on average 75 beats per minute. And the average height was 153 centimeters. In total, 340 participants had complete data for all four of these continuous variables. So we had a solid data set to work with for the rest of our analysis. And looking on the categorical side, some important key figures that stood out to me is out of all participants, 46.4% tested positive for cervical abnormalities. So almost half the women screened received a positive diagnosis. Of those who tested positive, a large portion, 37.3% of all participants were diagnosed with a high-grade condition, which is more serious and I believe needs more follow-up care. So what that all basically means is not only were a lot of women testing positive, but a significant number, or over 80%, are dealing with high-risk cases of the positive. So I believe these numbers just highlight just how important it is to catch these cases early and make sure there's a system in place for a proper follow-up, especially for those high grade results. And moving on, the first bit of analysis we truly ran was location versus diagnosis. And these were results from our chi-square analysis, where, yeah, like I said, we compared location and diagnosis outcomes. Yeah. And we ran a chi-square test of independence to see if diagnoses resulted varied by location. And from our p-values, they did. The Pearson chi-square had a p-value less than 0.001. Same with the likelihood ratio of less than 0.001. So essentially, both of these tests were telling us the same thing. Diagnoses outcomes are significantly associated with location. And the variation we're seeing across the different regions isn't random, it's statistically meaningful. And on the image on the right was a crosstabs result I ran, and we saw some clear patterns that really stood out to me. In Latacunga, 100% of the participants tested positive, and that was way higher than the expected, and I believe just clearly signaled like a red flag there. Sakua also had a high positive diagnosis rate at 64%, while others like Banos and Cahabamba were on the low end with 27.3% and 25% positive diagnosis, respectively. And yeah, these differences, I believe, just suggested that there may be real disparities across locations, whether it's underlying health risks, access to care, or even the effectiveness of screening and outreach in certain areas. And moving on from location, we did a logistic regression on age versus diagnosis. And here I found a very strong negative association between age and predicted probability. In simple terms, as age increased, the chance of testing positive went down. And I had a model fit. It was the fit was extremely high with the R square equaling 0.997, which meant that age alone explained almost all of the variation in the diagnosis probability. And that was a huge finding. Yeah, and then you can see the equation right there for probability. And essentially what that just means again in simple terms is so for every 1 year increase in age, the predicted probability of testing positive decreased by almost a percentage at 0.964%. And to give like a real world example, a woman who's 20 years old has a predicted probability above about 66%, but that same woman at 6 years old would drop around to 27%. And then on the right, we also ran a strong statistical evidence backing this up from the original logistic regression output with the coefficient of age being negative 0.041. And it was highly significant with a p-value of 0.001 with the odds ratio of 0.960. So on this statistic, it tells us for every additional year of age, the odds of testing positive decreased by about 4%. So Yeah, in short, the model clearly showed that age is a strong and reliable predictor of diagnoses outcomes, and it gave us compelling reason to prioritize outreach and education for younger women since they appear to be higher risk based on the data. And we did an age versus diagnosis as well for t-test. And yeah, this test compared the average age of participants who tested positive with those who didn't. And the results showed a statistically significant difference with a p-value less than 0.001. So on average, participants with a positive diagnosis were 5.15 years younger than those who tested negative. I also calculated the effect size, and the Cohen's D was 0.457, which indicated a moderate practical impact. So not only is the difference statistically meaningful, but it also had real-world significance. It reinforced the idea that younger individuals in the population were higher at risk. And I believe these findings really lined up really well with what we saw with the logistic regression model, which also showed the probability of a positive diagnosis went down with age. So altogether, I believe this added even more support for age-specific public health outreach in cervical cancer screenings. Young women may not always seem like the highest risk group, but based on both the t-test and the regression results, they clearly deserve focused attention in future campaigns. Moving on from t-test, I ran a cluster analysis, and we used Word's method for this. So we looked at participant data based on age, weight, height, and pulse, and this helped us identify four distinct clusters. Each of these clusters had their own demographic and clinical profile. When we looked at how diagnosis outcomes were distributed across the four groups, it gave us a really useful insight on who might be more vulnerable and whether we need to direct more attention. So starting with cluster one, this group was included older participants with elevated pulse and higher weights. And so even though their vital signs may raise a concern like high pulse or weight, I believe they weren't the group with the most positive results. And this suggested that age or cardiovascular markers by themselves might not be enough to predict cervical cancer risk. Next was cluster two, and this was the youngest and leanest group. This group definitely stood out to me as one of the biggest takeaways, as even though they're young and relatively healthy looking, they tested positive more than anyone else. This could mean early HPV exposure, or maybe they just didn't have much access to screening and prevention. Whatever the reason, it was clear to me that this group needed targeted education and screenings. They're easy to overlook, but clearly at risk. And following that, we had cluster three. This cluster is made of up to mid to older adults with the lowest weight and shortest heights. And this is the group that might be dealing with nutritional or socioeconomic challenges. And the combination of moderate positive outcomes and physiological characteristics suggested to me that follow-ups and maybe additional support services could really help this population. And finally was cluster four. They were the oldest adults with the moderate health indicators, and I believe a possible explanation here of why they're so low is they have more access to screening or health education in the past. Either way, we shouldn't ignore this group, and I believe they still need continued screening and monitoring. Um, yeah, and then for this, we also made a stack bar chart on the right showing diagnoses outcomes by clustered, and the pattern was pretty clear. As I said before, cluster two really stood out as the highest number of positives, despite the youngest and physically healthiest group on paper. I believe that's why looking at multiple variables together matters. And I also ran a chi-squares test for diagnosis by cluster to see if diagnoses outcomes were statistically tied up to cluster groups. And both the Pearson chi-square and the p-value, the chi-square was at 16.85, which was pretty high, and the p-value was less than 0.001. So that basically just told us that there's a statistically significant link between which cluster someone's in and whether they had a positive diagnosis. So this means that demographic traits like age, height, weight, and pulse, when combined, do make a real difference in cervical cancer outcomes. It's not just one factor in its own, it's the interaction between all of them that mattered. And moving on from cluster, we had the BMI. We calculated BMI in SPSS using the formula. It's the fourth bullet point right there. and this allowed us to standardize body composition for all participants. And independent samples t-test showed no significant difference in BMI between those with and without a positive diagnosis, as the p was at 0.52, with a very small effect size at 0.069. So this suggested that BMI was not meaningfully associated with diagnoses outcomes in the sample. Moving on was our pulse, and we looked at whether pulse rate categorized as normal, which was from 60 to 100, or abnormal below 60 or greater than 100, was associated with diagnoses outcomes. And for this, I ran a chi-square test of independence to compare the frequency of positive and non-positive diagnoses across these categories. And as you can see on the chart on the right, while a slightly higher percentage of individuals with a normal pulse tested positive, about 56% compared to the 45% in the abnormal group, the difference was not statistically significant. The Pearson chi-square result was 0.773, and the p-value was 0.379, which was well above our 0.05 threshold. So based on these analysis, we conducted that we concluded the pulse category was not meaningful predictor of cervical cancer screening results in the data set. I believe it still remains a valuable vital sign for general health monitoring, but maybe nothing to take home for screening outcome predictions in this context. And then moving away from that, we did a program performance, and for this, I started with medication. So the most commonly prescribed medications throughout our campaign were methron. I'm sorry if I say this wrong. It's methrodiazole and acetaminophen, which was given to almost 26% of participants, and doxycycline combinations, which were given to around almost 12% of the participations. These are typically used to treat bacterial infections, so it showed that infections were a common issue during screening. And from medical insights, I'm going to be looking at the procedure insights now. The most frequent was the cervical catheterization, which was performed on almost 38% of cases. This told us that a lot of women were showing visible lesions, and I mean that is apparent from the evidence I showed before. While on the other hand, about a quarter of the participants, which was 26%, were advised to return for a pap smear in 1 year, which was actually a good sign, and it meant people didn't need treatment right away, but still needed monitoring. For serious procedures like biopsies or referrals for surgery, that was much less common, but still important, and these cases are likely to need follow-up and could turn into something more severe if not addressed. So overall, the program was strong in identifying immediate treatments, needs, and giving people a clear plan to follow up. But I believe there's definitely ways to improve. For example, medication data wasn't always clearly connected to diagnoses or procedures, which made it hard to tell if everyone got the exact care they needed. So yeah, moving on from the statistical end, I want to have kind of like a overall performance on everything. So starting with our communities or the recommendations for communities. First, I believe we need to focus more on younger women. Um, our data showed that women under 40 were actually way more likely to test positive. Uh, so that told me that we need to put more energy into reaching the younger groups, maybe through schools, university, youth events, so they really understand how important early detection and regularly screening are. Second, I believe we got to expand outreach in rural and high-risk areas. The diagnoses rates weren't the same across all locations. Some rural areas had much higher numbers, so we need to send more mobile clinics possibly and do more targeted outreach to those hotspots. That way, women don't live near health centers, still have a real chance to get screened. Third, I think boosting awareness on any confusion around HPV and screening. Almost half the women screened tested positive, and yet there's still a lot of misinformation and stigma around HPV and cervical cancer. So I believe if we're using tools that are already in works in these communities, like local radio, WhatsApp messaging, and personal stories, I believe that would really get the word out in a way that feels familiar and trustworthy. Fourth, follow-up care really needs to be a part of the plan. Our analysis showed that a very few women who tested positive actually got treatment or follow-up care, and we can change that by having a community health workers check in with them through possibly phone or text and helping things like transportation if needed. I believe this extra step can really make a big difference. And fifth, I believe we need to encourage ongoing screening, not just one-time visits. Right now, many women in Ecuador only got screened if there's like a campaign going on. So I believe we need to make it easier for them to stay on top of their health year round. Maybe one way to do this is by partnering with local employers, churches, or even market vendors to remind women to get regular pap smears and treat it like a normal part of their healthcare. And lastly, I believe local leaders really mattered. We saw clearly that location and community context made a big difference in who showed up. So I believe working with trusted people like we've done before, like people in the past, church leaders, even teachers, and trained them how to become ambassadors for screening. When the message comes from someone they know, I believe people are a lot more likely to listen and act. And moving on from that, I believe program improvement. So, first, I believe we need to strengthen follow-up protocols. As I said before, results showed that a fourth of the women were advised to return for a pap smear, and a smaller percentage needed advanced procedures like biopsies or referrals. However, we did not have a plan in place for women to receive follow-up care. I recommend developing a formal tracking system with dedicated staff assigned to contact high-risk women by phone or text. Even partnering with local centers that previously helped us reach the local communities can help close the loop and ensure that no one falls through the cracks after their initial screening. Next, I believe we need to use the cluster analysis to sort participants into four groups based on age, weight, height, and pulse. Each group has different needs, so tailored suggestions for follow-up care, I believe, would be really helpful. For example, cluster one included middle-aged, heavier women with higher pulse, and I believe this group might face higher risk of, like I said before, heart or metabolic issues. So recommending adding a glucose screening to their visits would be helpful. Cluster two was the youngest and the leanest woman, yet they had the highest rates of positive diagnoses. So I believe continuing health education and prevention efforts with them would be really important. Cluster three was the older, lighter, and shorter women. So they might be at risk for nutritional risk. So offering dietary support or nutritional counseling would be very helpful. And lastly, cluster four had the oldest and heaviest participants. So given their profile, I believe they should be prioritized for regular and following up like monitoring. And by using these clusters, I believe we can focus resources and make our interventions more effective for each group. From going away from that, let's talk to our third point. I believe we should increase outreach in our rural and high risk areas. The chi-square analysis found a significant difference in the diagnosis rates by location, as the p-value was less than 0.0001. So some regions showed notably higher rates of positive results. I believe direct and more frequent mobile clinics, as I said, and additional health education resources to these hotspot areas would address the disparities and provide equitable services. From that, fourth, I believe boosting the patient education and prevention messaging. Keep reinforcing this idea that half of the patients screened women had a positive diagnosis, and younger women were at even a greater risk. So I believe integrating HPV and cervical cancer education into every clinic encounter would be really important. Using easy to understand pamphlets, like I said before, WhatsApp messaging, and local radio in Spanish and Quechua would really encourage women to return for follow-ups, and I believe bringing their friends and relatives. And lastly, I believe monitor and refine the program metrics. We found no significant differences in BMI or pulse between positive and negative groups, suggesting that traditional screening metrics might not fully capture risk. So, continuing to refine which data points best predicted high risk cases, expand surveys to collect information on education, income, and healthcare access may help with finding true influences. I believe together these steps would help VB-SPAM and PACH build on program strength, address gaps, and make cervical cancer prevention efforts even more impactful for those across Ecuador. And lastly, I believe what I believe the PACH board might might be most important for them is firstly we need to, I believe, keep building local capacity. That means continue to train healthcare providers and community health workers not just on how to screen, but how to follow up and be trusted messengers in their communities. This is how we make sure the work keeps going even after we leave. Second, I believe it's time to strengthen our partnerships. If we formally grow connections with possibly the Ministry of Health, local NGOs, universities, and even indigenous-led organizations, we can reach even more people and fill in gaps and build something that lasts. Third, I believe investing in digital health records is really important. By using secure cloud-based systems, I believe we can connect campaign data to local clinics and even hospitals. This would help real-time follow-ups and give patients a better chance at long-term care. Fourth, I believe we should plan more data-driven. We've done a lot of work using cluster analysis and other stats, and that should guide us on how we plan future outreach. It would help prioritize the communities with the highest risk and the most with barriers to care. Fifth, I believe advocating for policy change is key. If we can work with health officials to integrate PACH's protocols into the public health policy, we can create a system that supports cervical prevention at its scale across provinces and into the future. And finally, I believe we should invest in local leadership. As I said before, supporting indigenous leaders, women groups, and youth advocates could help build momentum from the inside out. These are people who know their communities best and can drive long-term change, like I said, the best. I believe altogether these recommendations aren't just about improving future campaigns. They're about building a system that is community-led, sustainable, and grounded in equity. And that's how we make sure Patch's impact keeps going. Yeah, thank you so much. And if you want more insight into the analysis, I made a whole report, and there is my statistical reference. Thank you.